Amyotrophic lateral sclerosis, ALS, which is commonly known as Lou Gehrig's disease, is a relentlessness, degenerative, and terminal disease that affects both your upper and your lower motor neurons. Massive amounts of your anterior cells of the spinal cord and the motor cranial nerve nuclei in the lower brainstem results in muscle atrophy and weakness. Amyotrophic literally means no muscle nourishment, and it is responsible for controlling voluntary movements in your arms, legs, and the face. There are two types of ALS, sporadic and familial. Sporadic is the most common in the United States, and it contains from 90 to 95% of all cases, and it can affect anyone, anywhere. And the familial accounts for only 5 to 10% of all cases in the United States, and this means that the disease is inherited. So in those families that have ALS, there is a 50% chance of each offspring will inherit the gene mutation and also will develop the disease. ALS belongs to the group of motor neuron diseases, and this is characterized by the gradual degeneration and death of motor neurons. Motor neurons, as we know, are nerve cells located in the brain and the spinal cord that serve as controlling units and vital communication links between our nervous system and our voluntary muscles of the body. ALS attacks both our upper and lower motor neurons, which causes them to degenerate or die, and it cuts all ties of communication to the muscles. So muscles gradually weaken or they waste away, which is also known as atrophy, and have very fine twitches called fasciculations. Unfortunately, the cause is unknown, but there have been many theories that have been proposed. The latest research concludes that ALS is related to a proteinopathy called DDP3. More than 12,000 people in the United States have a definite diagnosis of ALS, and the prevalence is 3.9 cases per 100,000 persons in the United States population. Individuals of all races and ethnic backgrounds are affected, and it is more common among white males, non-Hispanics, and persons aged 60 through 69, but it doesn't mean that younger or older individuals can obtain it as well. The disease presents itself looking more like a lower motor neuron disorder in that there's atrophy. They may also have spasticity in their lower extremities, but first symptoms are distal weaknesses. Many times it occurs in the intrinsics of the hands, primarily the left. Speech and swallowing can begin to become abnormal as well if the disease progresses, and fasciculations in the bicep where muscle contraction is periodic. Patients can come to therapists and explain that they're having a hard time with their left hand and say, I can't pick up things anymore and I'm constantly dropping things. An OT will actually see thenar eminence atrophy, and depending on how quickly the course will take is depending on how the person goes from being able to ambulate and use their extremities to being confined in a wheelchair and not being able to do anything at all. The systems affected once diagnosed with ALS include your skeletal, your muscular, your respiratory, and your nervous system. Once it hits the respiratory system, it ends up being the patient's demise because it directly hits the diaphragm, causing trouble with breathing. Family and patient then has to decide if the patient should be put on a respirator. ALS patients have a preserved bowel, bladder, sensory, and eye motion. Comorbidities include depression, joint contractures, and tightness in their tendons due to a lack of movement. And unfortunately, it's a death sentence once you get diagnosed with ALS because it's a disease that is progressive and it hits your entire body. Once an individual is diagnosed with ALS, on average they have about 2.5 years to live. Some can exceed it, but others may take a quick turn for the worst. No cure has been found for ALS, but there are different types of treatment. One of them includes respiratory management, which is putting a patient on a ventilator. Another is Riluzole, which is a putative blocker of glutamate release, and it is believed to reduce the damage of motor neurons by decreasing the release of glutamate. It only preserves 2 to 3 more months of an individual's life, and it doesn't do anything to slow the disease process down. Family members and the patient has to be aware that there are charlatans out there. It is a death sentence and there's no turning back. People are desperate and want to seek out to find a cure, but unfortunately they won't get anything. There are several different types of interprofessional team members, and everyone's main goal is to preserve the best quality of life as the disease progresses. Occupational therapists will specialize in helping people find and use tools to cope with the progressive weakness in the hand muscles. Speech therapy will be due to speaking ability being lost. Physical therapy can enhance an individual's independence and safety throughout range of motion and stretching exercises. And lastly, nutritionists support on how to plan and prepare numerous small meals throughout the day to provide enough calories, fiber, and fluid for patients. We as occupational therapists will be treating individuals with ALS. Some will say, I'm flying to the other side of the world because I found out that a doctor has a cure for me. Our role is not to say, no, don't do this. Our role is more of to present them with evidence as what we have in the United States and say, hey, this is our evidence, this is our treatment, and that's all we can really do for them. They have to make the decision on their own, and we can not feed into this as OTs. Many charlatans out there will promise patients that they definitely have a cure for them, but we can only do so much for them. 4 types of settings that people can be treated in are hospitals, home health care, therapy clinics, and rehabilitation centers.
Parkinson's disease, or PD, is estimated to affect 1 million people in the United States and over 10 million people worldwide. The incidence rate ranges from 4.5 to 20.5, with the incidence rate increasing as age increases. And that's backed up by the statistic that 1 in every 3 adults over the age of 85 has Parkinson's disease. PD is classified as a progressive movement disorder and a degenerative central nervous system disease. Its pathology is involved with a decrease in dopamine in the substantia nigra, which affects the direct and indirect pathways of the basal ganglia. These 2 structures are highly involved in our motor loop, and therefore Parkinson's disease affects the motor system and motor functions of its patients. With its effects being on the motor systems in its patients, Parkinson's disease presents classic motor characteristics. 2 of these characteristics are bradykinesia and akinesia. Bradykinesia is defined as slow movement, and the patient often has trouble initiating movement, gets stuck or maintained in a fixed position, and has a lack of spontaneous and automatic movements. Akinesia is a lack of motion, which is also classified as the inability to initiate movements, inability to perform purposeful movements, and also maintain a fixed posture. It also affects the ability of a patient to change the direction, change the force, change the speed, or stop a movement from happening. Another common motor characteristic in PD is rigidity, or the resistance to passive movement. An increase in muscle tone creates problems with stiffness and flexibility. It's most common in the limbs, neck, or trunk of a patient, and it creates decreased range of motion. Now, a patient with PD also has neural excitability that is disproportionate to the task. And a good example of this would be it requires just as much neural activity for a patient with PD to participate in an easy task like washing their hands as it does in a task for them to walk up the stairs carrying something heavy. Now, this may cause them to have a false perception of the energy that is required for a given task and may make them reluctant to participate in any movement at all because of how tiring it can be. 2 other motor characteristics that affect patients with PD are postural instability and gait issues. Postural instability leads to an increase in falling. More than 2/3 of Parkinson's patients fall at least 1 time over the course of the disease. 10% of PD patients report falling at least 2 times per week. Patients often display a hunched over stature, which is categorized by that postural instability. Now, the gait issues, decreased velocity, and stride length are directly related to that postural instability. The speedy shuffle gait that can be seen in patients with PD is often related to poor postural instability in that their momentum is carrying them forward and they're shuffling their feet very fast in an attempt to keep up. This is known as festination, and there's forward festination and backward festination. Forward festination being propulsion and backward festination being retropulsion. Another common motor characteristic of PD is the resting tremor. The resting tremor is described as a shaking or oscillating movement, and it's only present when the person is at rest or relaxed. The tremor often subsides when the person begins to engage in some kind of movement. This affects about 70% of people with PD, and is described as having a regular rhythm with an average of 4 to 7 beats per second. One tremor that's often seen is pill rolling. Pill rolling is a movement between the patient's fingers in which it looks like they're rolling a pill, kind of like this. And then they do it in a nice circular motion on a regular rhythm. All the motor characteristics that I've listed over the past couple slides, it's important to realize that their main complication is with complex movements, sequential tasks, transitional movements, and it causes delays in muscle activation, so their alertness is not as high as it should be. Outside of the motor characteristics previously listed, other physical characteristics seen in PD are sexual complications, fatigue, hallucinations, and the mask-like presence in which the patient often has a blank stare and a lack of facial expression or subconscious facial movements. There's also mental characteristics involved with PD, including cognitive deficits in attention, working memory, and visuospatial skills. The working memory deficit often leads to inabilities in procedural learning. PD is a progressive disease, so as time passes, the disease course gets worse. The prognosis for PD is that the initial symptoms are usually a resting tremor or unilateral bradykinesia. The next step is that the symptoms become bilateral and postural instability begins to be seen. The next phase usually involves the patient using some kind of assistive device to walk as a walker or a cane, and the last stage usually involves the patient becoming put in a wheelchair or bedridden. It's important to know that the actual degeneration of dopamine in the brain does not lead to death in the patients, but it is rather the complications that come from the symptoms of PD that lead to the death, such as not being able to get up and move as much, your respiratory and cardiac function become compromised, and respiratory disease is a main cause of death in patients with PD. Stages of PD is commonly measured by the Hoehn and Yahr scale, which is an 8-point scale. Stage 0 involves no signs of Parkinson's. Stage 1 is unilateral symptoms only. Stage 1.5 are unilateral and axial movement issues. Stage 2 are bilateral symptoms with no balance impairment. Stage 2.5 are mild bilateral disease and recovery on the PUL test. Stage 3 involves balance impairment, mild to moderate disease, and becoming physically dependent on others or assistive devices. Stage 4 is severe disability, but still able to walk or stand with assistance, and stage 5 is needing a wheelchair or bedridden. Another commonly used scale for PD is the United Parkinson's Disease Rating Scale, which is a more comprehensive scale, and the stages involve more than just the motor symptoms present. Parkinson's disease has a few comorbidities that often are seen. Depression occurs in about 50 patients with PD. Psychosis occurs in about 20 to 30% of patients with PD. Dementia occurs in about 30 to 93% of the patients with PD. And bronchopneumonia, which is the most serious complicated associated with PD, and is often the cause of death in patients with Parkinson's. As of now, there's no known cure for Parkinson's disease, and all interventions for Parkinson's aim to slow the progression and alleviate the symptoms. Pharmacology is a common used intervention, and there are drugs given to reduce the dopamine degeneration that's going on in the brain, as well as reduce the symptoms. L-DOPA and specific dopamine agonists work by facilitating or contributing to the amount of dopamine being produced in the brain to try to counteract the degeneration that is currently happening. COMT inhibitors also try to counteract that degeneration by inhibiting the reuptake of dopamine at the postsynaptic potential. Amantadine is a commonly given medication used for reducing the symptoms of rigidity and bradykinesia by facilitating the release of catecholamines. Other interventions for PD include surgical interventions such as deep brain stimulation or DBS. DBS is a reversible procedure that involves the implantation of electrodes on the hypothalamic nucleus to increase activity in this area of the brain. This helps alleviate all symptoms of Parkinson's disease. There's also DUOPA, which is a surgical implantation of a tube to help feed drugs like L-DOPA and carbidopa into the bloodstream. Other alternative interventions are often revolved around physical therapy or physical exercise that help offset dysfunctions in balance, gait, dual task performance, and rigidity. Exercises such as dancing, ball activities, or stationary exercises decrease the chance of respiratory and cardiac dysfunction. Common settings for many of these interventions to take place are hospitals, skilled nursing facilities, assisted living facilities, and the client's home through some kind of form of home care. Common interprofessional team members that carry out these interventions are movement disorder specialists, PTs, OTs, SLPs, social workers, and the caregivers who are made up of nurse practitioners, home health aide, or family members taking care of the patient. Multiple sclerosis, or MS, is a disease that affects 350,000 to 400,000 people in the United States and over 2 million people worldwide. It is most commonly diagnosed between the ages of 20 and 50, and women are 2 to 4 more times more likely to be diagnosed, but men are more likely to have a worse prognosis and worse disease progression. MS is a central nervous system disease that is immune-mediated and classified as a chronic inflammatory disease. T cells of a person's immune system attack the neural tissue of the CNS. The attacks are in forms of inflammation, and they happen in areas of the brain, spinal cord, and optic nerve, and the cause of the T cells to attack its own neural tissue is unknown. The inflammation results in damage to the myelin sheath and damage to the neurons and axons of the neurons. The damage to the neurons causes damage to neural pathways of the central nervous system. Now, it's important to know that the location of the damage can be of wide variety. As I said, it could be in the brain, spinal cord, or optic nerve, and it's anywhere within those structures. So it's important to know that the systems that are going to be affected in the patient are directly related to the location of where the MS has affected. To diagnose MS, there must be damage done in at least 2 areas of the central nervous system. The damage must have happened 1 month apart from each other, and all diagnoses must be rolled out before making a diagnosis of MS. Tools used to make the diagnosis are an MRI, which shows white spots on the areas of the brain where water has collected due to the decrease in myelin. There's also visual evoked potentials, which tests the electrical activity of the brain by exposing someone to different stimuli. Slow electrical conduction is usually an indication of demyelination in the brain. And then there's cerebral spinal fluid analysis, which assesses the cerebral spinal fluid for proteins that would only be present due to a breakdown of myelin in the brain. Although the symptoms seen in MS are highly variable, MS can be classified and put into patterns seen in the course of the symptoms. There's 4 types of MS. Clinical isolated syndrome, which is the initial episode of neurological symptoms, and it must last 24 hours to be diagnosed. Now, this may or may not develop into MS, so you can have clinical isolated syndrome without a reoccurrence of another episode, and it would never develop to MS. If you did have another episode, then there are more types of MS that it could be. It is relapsing remitting MS, which is defined as clear attacks or episodes of new neurological dysfunction, followed by a period of remission. The new attacks are the relapse phase, and the period where the symptoms lessen or disappear would be the remission phase. This is the most common type of MS as it makes up 85% of MS cases. Primary progressive MS is described as the neurological symptoms of MS progressively getting worse without a relapse or remission phase. This is less common and only affects 10 to 15% of people with MS. Then the 4th type is the progressive relapsing MS, which is kind of a combination of the 2 previous, and the person often has relapse remitting MS, but even during the phases of remission, her symptoms progress, but there is no new attack happening. MS symptoms can be very unique, as I've stated before, but some common symptoms are present in a lot of cases. Some common physical characteristics of MS are fatigue, which appears in about 80% of the patients, numbness and tingling in the face or extremities, which is often one of the first symptoms noticed, vision, which is also one of the first symptoms noticed, and is characterized by pain with eye movement or blurred vision, dizziness or lightheadedness, sexual dysfunction, spasticity of muscles, weakness of muscles, which can also lead to gait issues, pain. 55% of people with MS experience clinically significant pain in soft tissue, muscles, or tender spots on the body, and bladder problems, which is also prevalent in about 80% of people with MS. There's also common cognitive symptoms of MS, which include emotional changes such as mood swings, irritability, uncontrolled laughter or crying, and also depression, which affects about 26 to 50% of patients with MS. And then there's cognitive deficits in areas of memory, problem solving, attention, and executive function. Some common comorbidities are fibromyalgia, which is diffuse pain throughout the soft tissue of the body, inflammatory bowel syndrome, which is an inflamed parts of the digestive tract, often presents itself as Crohn's disease or ulcerative colitis, and then epilepsy, which is unpredictable seizures, and mood disorders, as I mentioned, such as depression, anxiety, or bipolar disorder. Interventions for MS are specific to the type of MS and to the location of the neural damage in the CNS. The location of the neural damage is the key to figuring out the systems that are going to be affected by the MS and therefore the interventions that are required to be put in place. Pharmacology for MS is in terms of giving medications to treat the immune dysfunction as well as treat the symptoms that accompany that immune dysfunction. So disease-modifying agents, DMAs, are used to reduce the immune dysfunction and to prevent inflammatory response in the CNS. The majority of DMAs are injected. There's also corticosteroids, which are usually given at the beginning of a relapse stage where the inflammatory response in the brain is really strong, and they're giving at high doses for 3 to 5 days in order to really try to reduce the inflammatory response and hopefully reduce the damage that will happen. Now, medications for symptoms can be anything, and it's really dependent on the symptoms that they show. Some common medications are bladder medications, mood stabilizers, or pain medications. Other interventions outside of medications for MS include the use of rehabilitative intervention, or restoring lost functions and adapting the environment to fit the patient's current performance level. There are currently no surgeries to help MS. Interprofessional team members that will carry out the rehabilitative services, again, are really dependent on the systems that are affected and are on a case-by-case basis. But some common members of the team are a neurologist, nurse practitioners, the physician, OTs, PTs, SLPs, vocational therapists, neuropsychologists, and any other therapist that can assist in rehabilitative intervention. Some common care settings for these patients are inpatient hospitals, outpatient clinics, skilled nursing facilities, home care, and community health centers.
Guillain-Barré syndrome is characterized by rapidly developing motor weakness. It affects nerve roots and the peripheral nerves, usually has a good prognosis, with most patients returning back to their prior functional status 1 year after the onset. Spinal roots and peripheral nerves are infiltrated with macrophages and T lymphocytes. The macrophages then attack and strip the myelin sheath, and damage caused to the myelin sheath will have a distribution in salutatory propagation of the action potential and results in slow conduction velocity. The incidence is approximately 1 to 4 cases per 100,000 persons, which can also be summarized as a rare disorder. A variant form is acute motor axonal neuropathy, which has a good prognosis. Less common forms are acute motor and sensory axonal neuropathy, which has a less positive prognosis. Studies show that males are affected twice as often as females, and an increased incidence of GBS following infection with the Zika virus. Some of the systems affected that come from GBS are your immune, your peripheral nervous system, your respiratory system, gastrointestinal, motor function, as well as your sensory system. Common characteristics can occur a few days or weeks after a patient has had symptoms of respiratory or gastrointestinal viral infection. Motor weakness develops rapidly, and symptoms appear on both sides of the body, which can cause quadriplegia. And there's distal to proximal weakness. Tendon reflexes are usually compromised, diminished, and absent. There's muscle atrophy, lower extremity spasticity, and if disease travels from distal to proximal, it can affect the diaphragm and compromise a patient's respiratory system. Severe fatigue is present in 38 to 86% of patients, and sensation can be affected, but it's going to show characteristics of your peripheral nervous system. There aren't many comorbidities when it comes to GBS. Approximately 27% of patients with GBS have no identified preceding illness. More than 2/3 have symptoms of an infectious disease prior to the onset of GBS. Majority of the time they can trace it back to the Zika virus. The Zika virus attacks the neurological system, and they've had many number of cases with adults that are also presenting with GBS and resulting from Zika, and another comorbidity can be the Epstein-Barr virus. Medical treatment depends on the rate and the degree of the ascending paralysis. Excellent supportive care during the acute stage is extremely imperative. All patients must be closely monitored for the rapid onset of pulmonary and cardiac decompensation. There are also non-steroidal anti-inflammatory drugs that can be used, and immunotherapy-based treatments. The first is the plasma exchange, which is the biggest treatment, and it is the removal of plasma from withdrawn blood with retransfusion of the formed elements back into the blood. And the second one is the intravenous immunoglobulin, which is taking blood from a vein, separating the plasma, and then returning the blood cells with a plasma substitute. The interprofessional team members involved with the GBS patient include physical therapy, which uses range of motion exercises and reduces functional deficits to target repairs and the disabilities. You have speech therapists to promote speech and safe swallowing skills. And lastly, you have occupational therapists who promote activities that aid functional self-care and energy conservation techniques. The importance of occupational therapists who treat patients with GBS have to build up their strength. It is very important that patients are not overexerted because this can cause a setback for them. Within the first 2 weeks of diagnosis, we have to be very careful not to over-fatigue them so they don't have a relapse. 3 types of settings that we treat them are hospital, rehabilitation centers, and as well as inpatient and outpatient care. The true differences in the neuromuscular disorders that Zach and I looked at were for Parkinson's, individuals have resting tremors, increased tone, and specific gait and posture. With MS, they have increased tone, but it can hit every single system in the body. In ALS, you have atrophy and involves the entire body, and individuals only have preserved bowel, bladder, and eye movement. And for GBS, it can hit every system, but there's going to be a flip, meaning individuals bounce back from it and are able to recover. Thinking about progression and availability for treatment, from having the most hope to the least hope of recovery, goes from GBS to MS to Parkinson's disease and ALS. In GBS, like I said, it does hit the entire body, but many individuals bounce back from it and are able to live. MS, the same thing, hits the body, but people are also able to live. In Parkinson's disease, nobody dies from actual Parkinson's disease itself, but from the symptoms that comes with it. And for ALS, unfortunately, once you are diagnosed with it, it's a death sentence.